Thank you, Mariah. I appreciate it. I appreciate the opportunity to be here, and welcome to everybody that's here. After listening to my titles and all that stuff and talking about educational research, actually reinforces kind of one of the points I'm trying to make, which is that educational research is just research. And in that, we have a lot of opportunities to think about it a little bit differently. And that's what this is going to be about. This is a little bit from my history of reviewing educational research in several different roles, as an editor for a journal, as for conferences and different other activities. I've come across a number of things, and this talk is about a few things that can help when you're thinking about how to get your head around some educational research. We'll talk about kind of what that means in a second here. So let's see if I can advance slides. There we go. It's lagging a little bit. There we go. And when we talk about educational research, I actually want to, I'd love to be able to sort of line through the term research and say scholarship all the time. I'm not going to, because I sort of default to research. But remember that this concept of scholarship is really important when you're thinking about educational research. I know and have seen and worked with a bunch of teachers, clinicians, scholars, whatever you want to call them, clinician teachers that really are allergic to the word research, it seems, and are at least either very reticent to dive into research or don't think they can do research. There are lots of different reasons for that sort of fear. And so one of the issues is to get away from calling it research so it doesn't seem like something you can't do. But we can't always do that. And so I want to dissolve a little bit of the concern around that and provide different ways that you can get into this field of educational research and scholarship that might help you feel better about it. So we'll talk about the nitty gritty of this. We'll talk about choosing study designs that can help with research, and they don't all and often can't be randomized controlled designs and those type of things. So we'll talk about that. We'll talk about ways to avoid bias when you're doing research, not in detail, and I'm going to present things that overlie this. So it's not going to be a detailed methods talk, but just some things to think about when you're doing that. So ways to avoid bias and enhance applicability for both qualitative and quantitative research. And then designing and develop a curriculum. This is the key. If you design and develop curriculum in a way that has you thinking systematically and programmatically, you can easily find ways to do the research. And I will excuse myself. I've been home with a nasty little virus that I contracted over the weekend, so I will try not to cough directly into the microphone, but I apologize if I do. Okay, my first hot take: educational scholarship is a faculty duty. And I do truly believe this. I think that the scholarship, the idea of getting our ideas out to the rest of the world, is really, really important. Even if you're, quote, just a clinical teacher. If you're in a residency program teaching residents, if you're just teaching students, we have a duty to not only do the teaching, but also improve how we do the teaching. And that takes a line from quality improvement. We have a duty to not only do medicine, deliver care in a good way, we have a duty to improve how we deliver care. And so that same thing can be said of educational research and scholarship. If you're familiar with Boyer's model of scholarship, many are. This is scholarship of discovery, which is traditionally the big R research, the method heavy research that we all know. There's integration, which is synthesis research, so systematic reviews and other systematic ways to integrate the research that's been done. The scholarship of application, how you get proven things into practice. So in the case of healthcare, getting evidence-based medicine into practice is a form of scholarship. So quality improvement and implementation science could be parts of that. And then teaching, and teaching is a funny one because it's not only teaching the next generation, but it's improving how we do teaching. So integrating each aspect of discovery, integration, and application into our teaching work, I think, is very important. And so you can, so there are ways that this all fits together, and some of the things we'll talk about, some of the opportunities we'll have, is to see how overlaying application and discovery on teaching and that a more systematic way of designing your teaching can help facilitate some of this scholarship. All right, but first, let's take a few stabs at some things that we might be able to do better in research. These are some examples, and we're going to go over these examples and come back to them at the end. So consider this scenario. A faculty member is under some pressure to do some scholarship. I think we've all heard that if we're trying to get promoted or the chair wants us to do some scholarship, we've heard about those sort of things. They read about a gamifying technique, could be Jeopardy, could be some other game that you can get your learners to play for teaching, and they apply it to their assigned lecture topic, and they study the following: how the residents rate the session, they study the knowledge before and immediately after the session, and they study the self-assessed confidence in managing the condition. Okay, so that's one scenario for and I've seen multiple examples of these in my career. It's one example of how a lot of educational research gets thought of. Second example: faculty member sees a problem with inappropriate referrals to their particular specialty, and pardon me, they create a survey or intervention for referring clinicians. Now, that's kind of interesting. The survey assesses knowledge about the referral guidelines for this particular condition and provides a link to PowerPoint education for the respondents of the survey. And then a follow-up survey is sent a month later assessing whether they learned anything from that PowerPoint education module. So I've seen this one go around a couple of times, actually. It's an interesting situation, and we'll go over the pluses and minuses of this a little bit later. And then finally, a researcher, this is what I've seen more recently, a researcher described a qualitative study of 13 clinicians across 3 states about their awareness of certain guidelines, found out that they weren't particularly aware in these interviews of some of these guidelines. And in their conclusion, they recommend a national call for action to improve knowledge of these guidelines. So think about the scope of those two things, the study and their conclusions for a second. All right. On to the opportunities. So keep those in mind as we go. One of the opportunities is to structure the educational development a little bit. We do this through a set of instructional design models or methods. And these are, I've talked about these before in previous teach lectures before. I come back to them. One, I have a degree in instructional design, so I'm likely to think this way. But 2, I think these are very accessible ways to structure how to develop curriculum that causes it to lend itself really well to educational research. So if you go in with this structure about how you're designing curriculum, you will be more likely and more able to develop that curriculum and research it. So this is the old tried and true one. It's certainly the one that I have the most experience with, the ADDIE instructional design model. What is this? So it's just a series of steps to think about as you're designing curriculum. They can be linear. They're often designed in different ways where learnings from one would flow into the other. It's not really terribly important, but just let's use them as things to think about. So the analysis part is when you understand what the need for the education is to begin with. So it could be national standards or calls for curriculum on a particular topic. It could be you found a problem with your learners and need to address that. So the analysis can take a number of different forms. Design is where you write the objectives for the education, and you design you choose the educational strategies, and you figure out how you're going to actually conduct the education. Development is in preparing to conduct the education or training, whereas a development of materials, development of assessments, faculty development to be able to introduce the curriculum, all these things go in the development bucket. Implementation is when you actually do it, and you study how you're able to do it and how well it goes. And then evaluation, which is really baked into the process the whole way down, is both summative and formative evaluation. How did each step go? And then overall, is the instruction meeting its ultimate goals, which you've designed back in the design phase. Very simple model. The reason this model is important is, as you can see, as I talked about each of these steps, there are lots and lots of potential research questions in there. And it's really it's really a sort of a target-rich environment for conducting educational research. And this is an important point I'm going to come back to. A lot of times, if we go into educational research without a framework like this, or without a plan about how the education was conducted, we find ourselves trying to literally boil the ocean, do way too much in our educational research, when we don't think about it like the FBRI researchers around here who are studying, a particular gene or a particular protein that have a very specific place in a long cascade of chemical reactions that ultimately results in a health outcome way down the road. And while I'm not generally a reductionist in terms of my focus in research, I think that model is important to realize that by breaking this down into different research questions using an instructional design model or some other model like that, it reduces the pressure you feel to prove that educating somebody can make a patient feel better down the road. You don't have to do that whole cascade. You can, by appropriately constructing a study, you can just study one notch in that chain and then move on and have actually a nice research program or research career researching different aspects of that particular instruction. So that's the fundamental basis here for why we're talking about instructional design frameworks. Those of you, I think, Sherry and Mariah, you can tell me, we used to use Kern's 6-step ID model, instructional design model, as one of the instructional design models that was taught in a lot of the faculty development that Teach has done. And so this is a very similar model, and it frankly doesn't matter which one you use as long as you get one that's been used around different places. So for Kern's, it has the problem identification and general needs assessment here, and a targeted needs assessment. So this just separates the needs assessment into two categories. One is the overlying need, the national calls for education, the program requirements, the RSC requirements, LCMA requirements, whatever it is. Targeted needs assessment would be your individual learners. What do they need? What deficits have you found that you need to address? Goals and objectives and educational strategies crossover between design and development in the ADDIE model. So you can see similar things there. Implementation is implementation. You're studying how it went, and then evaluation and feedback last. Again, perfectly reasonable to choose this model over ADDIE, just what you prefer. I'm trying to click what's going on. There it is. So now this is a different looking one, isn't it? So this is the 4-component instructional design model by a Dutch researcher called Van Marienborn. He has looked specifically, he and his group, he's passed away now, but his group looked specifically at instruction on complex activities like medical education, for instance, and divides them into different groups. So where you're learning specific tasks that are well integrated into these authentic whole task experiences, so a lot like what medical education would be when you're seeing patients. There's part task practice here where you're looking at things, and I'm not going over this, that you need to know this, need to know the details of this particular model, but look at the questions that it would come up. How do you make a more authentic whole task experience for learners that would lend itself to this model? Down here is the supportive information. So this is a sort of what they call a constructivist area. If you surround the learners with information and knowledge to be able to improve their practice, they will consult that knowledge and use that, pardon me, when they're trying to perform. So, and then procedural information, how do you teach learners how to do specific procedures and do them over time? Lots of potential research questions in here that take you away from the traditional ADDIE and Kern's model, but into more specific areas of learning repetition, maybe some simulation, and sort of you can break learning down into these various categories and study them particularly. Just an example, complex model that looked a little bit different than ADDIE. All right, so what's the big whoop with all these? First of all, the use of frameworks, in all of research, the use of research frameworks are valuable because they they make sure that you understand the context of your research question. It backs you up a little bit to make sure you know what's gone on before. You want to be able to use previous educational researchers' work in developing your own research. I think in medicine, I've seen we have a little bit of arrogance every once in a while when we think of some interesting thing and decide to teach it or decide to do it and some educational intervention we've heard without really understanding what's behind it. What's the learning theory behind it? Is it more cognitive behavioral, whatever? We'll get into a little bit of that later. Has this been done before, and in what settings? Is this an appropriate kind of which frameworks guide you to the most appropriate questions? That's the important of a model and framework, and some of that's about just a good literature search before you start, but some of it's also to understand what's been done, what's been worked on, and how can you advance the science beyond that. Research frameworks help you design better interventions, more appropriate interventions, and study better outcomes. You don't waste your time and money in repeating research. I see this a lot. We don't need a study about a Jeopardy game for teaching a concept in medical education anymore. It's been done multiple times before. So we need to kind of avoid those and do something a little bit more useful. It keeps you from biting off more than you could chew. Again, you don't have to do the whole prove the education works to create better doctor thing. You can work up step by step along those educational frameworks and do research that way. If you conceive of it as a multi-phase process and you're continuing to work on things as you go. Any questions about frameworks right now?
Nothing's popping up in the chat.
Okay. Yeah, I got the chat up.
Okay, good.
Yep. All right, we'll move on to study designs. Always my favorite category, but remember the underlying principle of this is that educational research should be good quality research. We do a number of things unintentionally, I think, to say that we often think that educational research doesn't need IRB review, and that's mostly wrong. That educational research is always QA and QI. That's also mostly wrong. It should be good quality research. It doesn't have to be particularly complicated. They don't have to be a lot of barriers there. But we got to choose the right study designs and do the research in the right way in order to get the good results that advance the field a little bit. Now, there are all sorts of barriers to studying our learners. Not their fault, but consent is one of them. Consent is a big issue. We don't get to just experiment on our students just because they're our students. So we have to make sure that we're towing the line with IRB regulations and all that to make sure that our learners are consenting to being in a research study. There are FERPA regulations. FERPA, for those of you who don't know, is the sort of the educational equivalent of HIPAA. It's a privacy act. So this consent and FERPA are very related, just like consent and HIPAA on the clinical side. So you can't just use test scores without sort of going through a certain process to making sure that the privacy is being respected and all that stuff. So you have to make sure you attend to those. The big thing in education is that you can't create differentiable educational opportunity. And what I mean by that is you can't randomize somebody to placebo learning. That ain't cool. Everybody that pays for their education or is assigned or is being paid to get their education, like residents, needs to have this similar education as much as possible. So you can't create a no education versus education thing. You could create comparisons in other ways, different methods, different modes, et cetera. But you want to be careful with that it's not a completely different experience. And then the final one is that the choice of the outcomes that you study need to be consistent with the stage of learning that the learners are in. I ran into this all the time, still run into it when talking about educational research involving evidence-based medicine. So evidence-based medicine often gets sort of put in the first 2 years where there's no clinical context or less clinical context. There's more now than there used to be. And so evidence-based medicine instruction was always meant to be taking real clinical questions from patients and then getting the evidence-based answer and applying it back to the patient. You don't necessarily learn that when you are in the first and second year. You don't have that application process. So I routinely struggle with that teaching evidence-based medicine when relegated to the first and second years, and struggling to get that of medical school, and struggling to get that into the third and fourth year, the clinical aspects, and getting that education reinforced and studying the right outcomes during the clinical area. So these are the issues we have studying our learners. It's just what we have to deal with educational research. Don't panic. You're not meant to read this. This is a study design graph, and I actually think this is a really, really useful handout. It's from the Cochrane collaboration, the Effective Practices and Organization of Care group. So this was a group that focused on kind of health services research, a little bit studying how care was delivered. They no longer exist as a group, but their materials are still out there. And there's a lot of parallel between health services research and educational research, in that we're often doing things in the delivery of healthcare where we don't want to randomize somebody to placebo versus the intervention of choice. We want to really sort of work on the airplane as it's flying a little bit. We want to make these interventions and then study their effectiveness down the road. And there's certain ways that you can do that in a valid manner. Those are highlighted in the blue. Again, I'll list them in a second so you can see them. All the rest of these little squares that are dead ends are less valid. They don't necessarily control bias as much as you'd want. So there are better and worse ways to do both educational and health services research, and they line up pretty closely. So what am I talking about? Over on the right-hand column, these three I've seen most often in educational research, especially the one with the red circle on it, the UBA, my nemesis, if you will, the uncontrolled before and after analysis. So this is, I measure something beforehand. I measure their knowledge of a certain thing beforehand. I put them in a session and teach them something, and then study them either right after or even a month after, and their knowledge goes up or down or whatever. The issue with an uncontrolled before and after analysis is you have no idea if your intervention actually did anything different, right? You have no idea if the delta, even if their knowledge went up, because you're not controlling the intervention. You don't know if your intervention is responsible for that change in their outcome. And yet I see over and over again, and I don't just see it here, I see it in health services research, over and over again. We measure an average beforehand, we do some intervention, educational intervention, and we measure some average afterward and claim success if it's higher. That just doesn't wash for educational research. It's too prone to bias and other secular, what they call secular effects and everything else. The whole range of other things that could be going on that cause that change in outcome that you're seeing that isn't necessarily due to the instruction. The other ones I see, case series. Case series are just studying, doing something to one person at a time. This is great, I guess, if you're worried that your education will kill your students. That's, and I'm teasing, of course, but that's kind of what you're doing, is you're making sure you don't put them to sleep or something like that. But it doesn't tell you whether your education is really effective. It's more of a phase one study for your education. So I would avoid case series. It doesn't really get you anywhere. It might be tempting if you ran a rotation, like a specialty rotation in residency, and you have only one or two learners coming through at a time, and you're testing some intervention that might feel like it's what you can do, but is not a great way to do research for that. Cohort studies, where where it ends up just being a observational study, are not as good. There are other methods where you're not actively randomizing people, or where you're not just observing them, might be better. But cohort studies generally are subject to bias, again, because of everything that goes on. And this is whether retrospective cohort or prospective cohort studies, where you have two groups and you're watching them over time, and one group is doing something else, and the other group is not doing something. You're comparing them. That doesn't really work, because there are all sorts of factors that might lead the one group into doing something at baseline that would change the outcome. So, pardon, my phone went off. There are ways to interrupt, to minimize bias, however. And so these are the strategies, the study designs that can minimize bias here. We talked about the idea of fixing the plane while it's flying, and that interrupted time series is one of the ways you can do that. So if you are measuring an outcome multiple times, like once a month, once a week, whatever, and you have a set of data points and you do an intervention, you do an educational intervention, and you watch for change in those data points over time, and you're basically running what are called regression analyses on, before and after the study. That's a valid way to assess for change that takes into account what are called secular trends. So it can be a better way to prove that something's worked without getting a control group involved. You could get a control group involved. You do a control before and after study where you're measuring the change from baseline to end, and you have a control group and a non-control group. This is hard to imagine in educational research. I don't see that much, but that might also link to the non-randomized trial here, where you down at the bottom, where you're not randomizing, but you're implementing something in one group, and maybe you have a friend in a different university and they're not implementing something, and you can assess students on both ends. That's the control before and after part of it. You might be able to do that. Randomized control trial and cluster randomized control trial are sort of the gold standard, but as we've said, it's often difficult to assign somebody to no education, and so that might be hard. I've seen in education larger cluster randomized trials, so medical schools innovating about something, comparing themselves to other medical schools that have not done that yet. As long as you're within the medical school or the residency and doing everything the same way, that's less of a concern to accreditation agencies than if you're varying the education within a single institution. So I have seen the cluster randomized trials on that scale. Repeated measure study is similar to an interrupted time series. You just measure multiple points and you're able to assess differences that way. Point of all this being, I'm not going to give you, I don't claim to be able to teach you all of study design in a single slide here. The point is that there are better quality study designs to do educational research than others. And please try not to default to this uncontrolled before and after analysis. I see it far too often. Qualitative research also has rigor associated with it. It's hard for people who are quantitative researchers to get their minds around what that rigor is sometimes. They need the blinding, they need the control, they need all that sort of stuff. Qualitative research is different research, but no less rigorous. And so the method or framework you use to base your qualitative research, whether it be grounded theory or immersion crystallization, those type of methods, they exist. There are lots of different ones in qualitative research. You should use one of those. Think about your sampling, who you're getting for qualitative research, who are you asking, who are you bringing into focus groups, who are you interviewing, how are you doing that? How do you get your text for analysis? Is important. Is it just open-ended comments, or are you soliciting information? And then the analysis is really important. Rather than getting rid of bias, you just have to acknowledge your bias in qualitative research analysis, that you have certain biases as an investigator. You go through a process of what's called reflexivity, where you talk about your biases. Well, Dr. Epling, he does evidence-based medicine stuff and really likes numbers and statistics and boring stuff. So he's going to have a certain point of view when he goes in and asks about this. All that's really important as part of designing qualitative research. You want multiple perspectives, so you don't just want boring old Dr. Epling analyzing the data. You want somebody that doesn't have those sorts of biases, and you get people with multiple perspectives looking at your qualitative data, and that's really helpful. And then member checking is the third way to validate your analysis. You go back to once you've themed out your the qualitative comments and developed your themes out of that with all the different perspectives and stuff. You show those back to the people that participated in your study. You say, did this capture what you were talking about before? Was there anything that we missed here? And that's member checking. And then being careful about generalizability. The purpose of qualitative research is not to generalize to a population. The conclusions of qualitative research are meant to look for and develop ideas and meaning and potential significance And they're really good for distilling down lots of thoughts into themes that sort of hang together so that you can, if you need to do quantitative research on them later, might be a good idea. But they're not meant to generalize to a population because you haven't done the things in quantitative research that enhance that generalizability. So be careful when you're doing your conclusions of qualitative research. All right, so why do we worry about study designs? One, so RCTs aren't required, but UBAs are unacceptable. So somewhere in the middle there's a good study design. And I'm certainly not saying that everybody needs to do randomized controlled trials because they're not feasible often and they're not really wanted in education. Poor quality studies, whether it's the choice of intervention or the outcomes you're studying or something like that, they take time and resources. You have to consent people to be in them. Poor quality studies are unethical. A lot of IRBs, we don't have this at Carilion Clinic IRB for a number of reasons that aren't necessarily bad, but a lot of IRBs, even for the low risk studies, do not have researchers looking at the quality of the study for rigor. In several previous places I've been, they would send even the low risk studies out for researcher review to determine if the study is likely to show an effect, if it's has a good framework behind it, you're studying the right outcomes, all that sort of stuff. We don't, Carilion Clinic IRB doesn't do that. And so we often get the mistaken impression that sort of any old study we can put together, as long as it sort of conforms to the IRB, is okay. But I'd want you to really focus on quality and make them the best studies you can using some of these principles and others, because otherwise we're just wasting people's time and effort. And the better you design your study, the better chance you have of getting it accepted somewhere for dissemination. So in a publication or presentation, the higher quality research gets you published better. About the IRB, they should not be an object of fear. Our IRB is really, really helpful here, actually. I work with both Brooke and Meredith, mostly because I end up doing the low risk studies mostly. And they're really wonderful. They have to take their stance about things, and you understand that. But if you consider that consultative to keep you out of trouble, that's a really good service. And so they're really good at finding ways to keep everybody on the straight and narrow regarding research. My opinion is that most useful educational research is not QA or QI. It might be exempt because it's done in an educational setting, but it's really not QA or QI. QA or QI, you're implementing evidence-based practices and maybe studying how they were implemented. That's different than trying a new instructional technique and seeing if it works. And so you have to keep your research questions really carefully delineated there. All right, so the very bottom line, no unsystematic biased experimentation on learners. That's not okay. But getting a good study design and focusing your research, you can use that creativity and passion maybe over several different studies, and that's the better way to conduct it. All right, last little bit here. Sorry, my pushing it won't go. Outcome frameworks. So this I have presented before, so I apologize if you've seen me talk about this before. The old Franklin Covey or the Stephen Covey quote, "Begin with the end in mind," is very important here. And it comes down to this question. How do you know that somebody learned? How do we know that and this is as applicable in our education as it is in our educational research? How will you be able to show that somebody learned something? And I've sort of given it away right there. Well, we talk about understanding, we talk about knowledge and all that stuff. But in the end, to be able to assess knowledge, to be able to assess understanding, we have to have some sort of demonstration of that knowledge and understanding. And that's where I think people get a little off base with learning objectives, and then are sort of hopelessly at sea when it comes time to actually research those learning objectives. So what am I talking about? The answer to this is good old Bloom's taxonomy. It's not the only answer, but it is an answer. And it what it does is it merges that cognitive stuff that basically is the big black box inside our brains about how we understand and remember and analyze and do all those things. And it translates those into behavioral things that we can observe, and both for educational outcomes as well as for research outcomes. Okay. So the bottom line here is when you're this is the link between educational objectives and research. When you're doing this sort of thing, use the behavioral objectives as observable things to be able to assess for your learners to understand whether your educational intervention has helped. So when you ask, understand is the big one. We all want to create an objective that says the objective is that they will understand this. Well, no, I mean, we can't go into their brains and figure out if all the connections are there for them to understand it. So we have to ask them to do something. They could explain it, they could describe it, they could predict something, you got to get to the verbs. And that's the most important thing about Bloom's taxonomy. If you like this, I have a bigger taxonomy for you with more verbs. And you can search online. There are 1,000,006 images that have this basic format. What I like about this is, one, it gives you all sorts of different verbs to consider and gets you thinking about the type of, not only the type of instruction and outcome that you want to write into your educational objectives, but also about the sort of research that you end up doing. And if you look at this, the example learning objective over here, learning objectives are written in a fairly researchable way. If you're a common research question, especially in evidence-based medicine, is the PICO question, the patient or patients, the intervention, the comparison, and the outcomes. Here we have the patients, in this case, are the students. We have those outlined in each of the questions. Whoops, sorry about that. We have the students. We have the intervention, which is whatever your learning is. That's what whatever the instruction is will end up resulting in the learning objective here. The comparison is sort of understood, and the outcome is written right here. They can design an original homework problem dealing with the principle of conservation of energy. You'll probably want to choose a medical outcome, but anyway. So understanding that if you write the learning objectives well, you'll be able to translate those directly into observable phenomena for research. That's the link there. Also, one of my favorite things that anybody knows me will attest to is this Kirkpatrick's training evaluation scheme. It's not the final answer, but it is a framework that has done me well, both in terms of writing objectives, but also in terms of research. I've used this in health services research as recently as a couple of years ago, because if you think about sort of how we affect practice change and how the delivery of healthcare is changed, it's often through either education or training. And sometimes we can, or at least that's a component of it. And we can use this sort of evaluation scheme to understand how well that works to actually change practice. It's a part of it. And we'll talk about that a little bit later, but this is a useful framework. So just to go over it again, for those of you that haven't seen it, the first level is reaction. That's, how tasty were the donuts? How warm was the coffee? Were the seats comfortable? Was the instructor entertaining? And I think a lot of our educational interventions are more about edutainment than they are about actual educational outcomes, but that's hot take. That's an opinion. Level 2, learning, knowledge. So this is the cognitive change. Again, just that if we're increasing knowledge, we have to be able to demonstrate that somehow. So you're still having to look at these level 2 outcomes as demonstration of that knowledge, demonstration of those skills. So think again about behavioral verbs to get to that. 3 is process change. So Kirkpatrick was an instructional designer in industry. So they looked for process change, the number of widgets made, you got, or actually that would be results. So how did you do things differently as part of your work that would result in the change in the results? So for this, we can say in the healthcare setting, knowing how to listen to the heart is one thing, but process change is being observed, actually listening to the heart differently. A result might be diagnosis of a heart condition under certain circumstances. So the results are the important outcomes for the patients or the learners, whatever you're looking at. So all sorts of different outcomes. I think in educational research, we tend to stop at level 1 and level 2. Often at level 1, this whole idea of the learners feel like they could do this thing well in clinical circumstances. I've seen that as an outcome assessed by survey. I'm not saying there's nothing to the idea of self-efficacy. However, it does not mean that they can actually do it in a clinical setting. So just their confidence, their self-rated confidence, or self-rated effectiveness in being able to do something down the road is more a level 1 outcome than it is, I think, a level 3 outcome. So just be aware when you're using this to not overstate the game a little bit. Kirkpatrick eventually decided that return on investment was a level 5 outcome, but I don't think anybody ever uses that. It's a difficult one for education to use. But I think this is if you combine Bloom's taxonomy with its focus on behavioral observable outcomes and Kirkpatrick's evaluation scheme to with each step in your research cascade get closer and closer to the level 4 results that we all want. I think that's the way to handle choice of outcomes and designing your research in a way that will actually advance the field a little bit. Clicking, there we are. One of my colleagues, this is the journal I'm associate editor for, the editor-in-chief is a friend of mine and wrote an article about moving on from self-assessment. So this is basically, we struggled. Primer is a journal for the Society of Teachers of Family Medicine, which is our academic society. And we pride ourselves in being a developmental journal. So we publish learner research as well as sort of junior faculty research. We try to get research out there that's maybe small ends or just part of the cascade that we're talking about, where you're studying little pieces and putting them together. So we try to we have a development focus. We try not to reject studies that have some potential and work with the authors to get them published. That said, at some point we were getting lots and lots of just these self-assessment outcomes. They were basically ratings at I enjoyed the course. I thought it was an interesting thing. I liked how the professor did it, and I feel like I could do this procedure or do this. I felt like I could take care of patients more. I feel like I could take care of patients better having completed this course. All self-assessment stuff really doesn't matter much. It's helpful to know, but it doesn't really help us much anymore. So that was his editorial for that. All right, so let's go. We're at the end here. Let's go back and practice. So we have our pitfalls from before. Sorry, the slides are really laggy. All right, faculty member under some pressure. They do the gamifying thing. They assess short-term knowledge, resident rating, self-assess confidence. Problems with this. Well, what's the underlying theory they used? They talked about gamifying, but did they go back and do the background search to see if gamifying's already sort of been proven to help, or at least led to some positive cognitive outcomes? Was this particularly novel, or has somebody done this over and over again? We find that a lot. Look at the choice of outcomes here. They're largely self-assessment, level 1 Kirkpatrick outcomes, level 2 Kirkpatrick outcomes, knowledge before and immediately after. At least if you can extend that cognitive outcome to 6 months down the road, then you have a sense that somebody may be able to do something and that your education has helped. Self-assessed confidence, again, might be helpful when you think about self-efficacy, but it's not the whole picture and can't be used to say, yes, mine works. This instruction works in improving how we manage the condition. So be careful of that. Now, there may be other things I'm interested to hear from you, but we'll move on to the second one. So the inappropriate referral problem. Again, I've seen this happen. So there are lots of problems with this one. One, apart from it being a little bit offensive to the referring clinicians, that somebody else would, sort of steal their watch and tell them what time it is. there's lots of assumptions about the problem. One, that the problem is knowledge, and so the survey has been worked into assessing knowledge and then immediately providing an education, thinking that the whole problem here is lack of knowledge. There may be all sorts of reasons for referrals or some complex process like that that has nothing to do about knowledge, nothing to do with knowledge of the referral guidelines. So this is where, if there's a lack of a guiding framework, you haven't done your background work sufficiently, you can get a little lost. Does education change practice? Now, I've told you about at least one study I've done that thought it was something that could help, but in general, education doesn't change practice. Education as a sort of an hour-long lecture, for instance, or some generic CME program, in general, they don't change practice really well. So if you do education, in the study I talked about, where we did some education and hope to see a change in things, we helped that education. We came back to it and refreshed the education. We gave job aids and other supports for the education to see if we could change practice that way. And so that's the sort of thing that if education is a component of this, that's great, but you often have to use other methods to make sure you're able to create a robust enough intervention that it actually changes practice. And then finally, in the spirit of nothing about us without us, unless you're collaborating with the referring clinicians to do the research, it all just seems a little heavy-handed. So be careful when you're doing stuff that looks like educational research that is in fact just bad practice change research. And finally, this was such a sad thing. The researcher that sent a qualitative study out, a solicitation to 2,500 clinicians across 3 states, got 13 interviews, and quite literally called for a national call for action to improve knowledge of these guidelines. First of all, there was very little in the way of background of this particular study. There wasn't a lot of, I don't think they knew their topic quite as well as they should. It's not they didn't have a particular focus research question. This lack of awareness of guidelines was kind of a different thing that they found. It wasn't really looking at, they hadn't planned to look at that a little bit. They're trying to generalize a problem. After interviewing 13 clinicians, they're trying to generalize the problem across the country and call for national call to action to improve knowledge. Just the wrong, it's the wrong way to go about qualitative research. There can be themes, there can be ideas for you to pursue, but you need to, if you're truly looking at generalizability from here, you've got to work on doing a quantitative analysis of the problem before you have some sense of generalizability. And then there's a whole field of qualitative rigor that wasn't addressed in this particular study. I shortcut it here, but how did they find those clinicians? Was it a purposive sample, or was it just sort of a convenience sample? How did they go about doing it? What method of qualitative research did they base their study on? All sorts of qualitative rigor that was not well addressed there. All right, you've done well if you've stuck with me to now. So educational research should be high quality research. Shouldn't be a question. That we need to not compromise the quality of the research just because we're dealing with learners and not a clinical topic. Pick a passion, find something that you're interested in researching, and then do small approaches to the topic. Use the instructional design frameworks to pick small questions and research them one at a time. And that passion will help keep you going from study to study. But that prevents you from sort of feeling like you have to boil the ocean for doing premature research that you don't really have a hope of making terribly valid, because often we're dealing with limited resources and other things. So find something and then bite off things that seem doable and study those. Use your educational frameworks and models to generate research questions to get ideas. It's often simpler than you think it will be to chew off those small questions and study those. RCTs are not required or even wanted, but there are definite alternatives that minimize bias. avoid the UBA, and then consider levels of the educational outcome, both in terms of which verbs, which Bloom taxonomy sort of level of understanding cognitive development do you want to look at, and then when you're looking at the effective education, which level on the Kirkpatrick scale could you look at, and one that's appropriate to both your subject and to the constraints, looking for level 3 and 4 outcomes when you're teaching in the first couple of years of medical school may not be appropriate yet. So you have different levels of outcomes for the stage of training that your learners are in. All right. That was enough of me, Amron. I'd love to hear your comments. That would help me to know. Oh, there are 32 people on. Wow.
Hey, John, David Music. Really appreciate your presentation. Very well done. Very helpful. Thank you. I'm really interested in this idea of the impact of education on clinical practice. And the whole approach to CME basically seems to be based on the notion that education would have an impact on clinical practice. I know there have been some studies, for example, that have looked at things like, you probably are aware of this, where future physicians' practice patterns are greatly influenced or impacted by where they do their residency training.
Yep.
So I don't know.
Not only that, not only that, but when they did their residency training. So there was a study that looked at their treatment of hypertension, and the sole explanatory variable was the amount of time since their residency training as to how they treated hypertension. But you're right. I mean, education has got to be part of it, right? And we have this. I think part of it is the lectures, the CME lectures that are the lectures that, if you're just sitting in a dark room and listening to slides, that's the stuff that probably doesn't change practice terribly well. Part of it is we need to understand the context of education. So we're sort of filling up the empty vessel for the first 2 years of medical school or something like that. We're pouring a lot of knowledge in, and that needs to be continually reinforced. And that's the whole kind of design of medical school. And then the question is, how do you update from there? And I think that that's where the individual lectures fall short. But we also know that incorporating other sorts of instructional strategies, looping back to education in a sort of a helix design or double helix design, as many schools have adopted, is important. The different learning theories probably contribute to this. So the ideas of social learning, where you're learning from peers and from mentors, is really important in medical education. And then constructivist theory is probably pretty important, where we select our students to be really high achieving and smart people. And if we just let them in a room with resources, all the resources they need, they probably just learn it themselves. And we keep proving that to ourselves, but we feel it's hard to let go of the teaching aspect of it a little bit. I think all those things contribute. And I think my issue is that when we fill out our CME evaluation forms, and I'm sorry, Deb, I'm gonna trample on this. If you're filling out a form that says, I feel like I will be able to do this better, I mean, that's just falling into that whole trap of self-assessment again. And I know the CME offices tend to use that question now, but because they want it to mean something a little bit better than just the reaction level advice. But I think that's limited a little bit. So
great stuff. Thank you.
A couple of comments or questions.
Yeah, Austin Drake. When is better the enemy of good enough? The studies you've referenced have been published. Sometimes seasons we don't come past the starting line because we're crippled by the pursuit of perfection. Oh, that's fantastic. So perfection. So perfection come across in a couple of ways, and I think it's my point about using these frameworks gets to that idea that perfection is often considered, my education will improve patient outcomes. And that's insane. That's really hard to prove that link. I think if perfection is, I want to find a way to measure higher up on the Bloom taxonomy for this little piece of instruction that I'm giving, I think that's a more reachable outcome. And so I think you can find you can find ways. Your drive for perfection needs to be tailored to your constraints and circumstances a little bit. Um, and if you can base it specifically on theory and show that you are advancing the field by, I know this framework and this theory, and I'm going to but here's a gap, we haven't studied it in this context or in this particular setting. That's what I'm going to do. You find it in evaluation, then you've advanced the field a little bit. I think that's what makes you publishable. Just doing the 60th study on whether Jeopardy makes resident lectures more fun is not all that helpful. Deirdre, I'm always searching for validated tools to increase reliability and rigor. Are there any good ones in educational research? Validated tools, you're there online. What sort of validated tools are you looking for? Just to be clear.
I'm stuck on measuring those outcomes.
Yeah.
How do we capture that? And I think a lot of times, I mean, again, with those pre and post things, and you're looking at your confidence level, there's really no way to get a measurement that's going to be accurate or what have you. I have the opportunity to train a bunch of people this summer, and they're from different majors and backgrounds, and I'm wanting to know if they're going to gain knowledge from I'll be doing a lot of work with them on soft skills that are potentially observable, but I'm trying to figure out what I can do to show that this program is making a difference. And are there things, I guess it's just tests that measured their knowledge, but then going in and doing, observations of their behavior on the unit with people.
Yeah.
I don't know.
Yeah, those are exactly the questions. And I think you're constrained by your circumstances because you have a diversity of learners coming all into the same program. And so one, you can study that. You can study maybe in a needs assessment framework, you can look and go, well, where are the deficits here? I don't know what you're studying, communication or what, let's just pretend it's communication. So do an assessment, an OSCE or some sort of maybe live assessment or a peer-to-peer assessment with ratings, and then look at communication deficits across different specialties or something like that, professions, and then maybe do that at the end. And you're trying to bite this into littler sections that are within your control and you have some ability to do because it's not overwhelmingly complex. And you're dealing with the important issues, which is how do you get heterogeneous learners all swimming in the same direction with your content or something like that. And that's the bit that I think is really hard for us to step back and go, okay, I can't prove that this will create better doctors or whatever it is that you're trying to do. But where's the gap here? What other programs have tried to do this, and where have they failed, or where have they not studied, and what can I do to take one step further, not 10 steps further? And I think that's the concentration.
Thank you.
Are there, sorry, to answer your actual, well, to address your actual question about validated tools, yes, but it depends on, it depends on what you're looking at. There is a systematic review organization called the Campbell Collaboration. It's a sister of the Cochrane Collaboration, the Campbell Collaboration. And they do systematic reviews across a bunch of different fields other than medicine, and one of them is education. You might look there. You might look at the Best Evidence Medical Education, BEME Collaborative, that is another systematic review group that looks at those. You might look at MedEd Portal for especially a place like MedEd Portal, because people often upload their tools and resources that they've created for other things. You might be able to adapt or coerce one of those to see if you can find that. And then just centering what you're trying to do in a framework, interdisciplinary education. Looking at those frameworks, you'll often find links to certain tools to evaluate those. I think that might help. Francis, hi. A minute discussing dissemination best practices dissemination of, so getting your research published, is that kind of what you're?
Yes.
Yeah. Yeah. So couple things. If we take a step back and go, the purpose is sharing, the purpose of scholarship is sharing, then I think you got to look at conferences as a perfectly reasonable way to disseminate. So specialty conferences, and they don't feel like you're writing something excessively scholarly if you're not trying to get published. I think publication is hard these days because a lot of the educational places require fees. And we just don't often have that much money. It's like $3,000 to publish in an open access journal. There are medical education journals, but in order to get into one of them, you have to have these, you have to have good, robust designs. You have to have the frameworks. You have to have all the things that we talked about. If you're just doing a pre-post sort of a UBA study, as I like to call them, they're unlikely to get published in a reasonable educational journal. So be aware of that. I think so doing the right sort of study designs, upping the rigor of your research is the first key. But then the second key, when we get to scholarship, is looking at your specialty societies, looking at educational specialty societies as AAMC, or the IMC, one of those areas to present research are the best ways to disseminate things.
I also like to think about going a little bit local, regional, national, some, and then maybe a poster, workshop, manuscript. And then like locally, just think about every year we have a Teach Education Day. Where we can come and submit an abstract, and it's really a low stakes opportunity to talk about your educational innovations. And then you've got a captive audience of people coming around and saying, well, have you thought of this? Or, you get that local feedback, and then a little bit bigger on regional and then national. So I think those opportunities can be outstanding.
Excellent point.
All
right, we're at time, I think.
We are. Thank you so much. This has been fabulous. Lots of great tips. Dr. Epling has always been fabulous about if you have conversations that you want to engage in, or you want to ask him questions outside of these sessions. He's always been super open to doing that. So
please do.
Thank you. And if you all want to talk about education and scholarship, the Teach office, Office of Continuing Professional Development and Faculty Development, we're always here for you to engage in those conversations and getting started within scholarship and really preparing for maybe a local presentation. So John, thank you so much for your presentation, and thank the rest of you for being here. Hope you all have a wonderful rest of the day.
Thank you.
Thank you so much, everyone. Have a great day.